Community clinics, or community health centers, got started in the 1960s when it became evident that access to health care was a major problem for many people in our society, particularly for low-income individuals and families, people of color and American Indians, and immigrants and refugees. Since that time, community health centers have become a critical component of our healthcare system. On today's episode of A Public Health Journal, we're going to take a close look at community health centers and the impact that they are having on communities throughout Minnesota. Please stay tuned.
Welcome to A Public Health Journal, a program that explores the public health issues facing our society today and tomorrow. The host of our show is Dr. Ed Ellinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health, the Hennepin County Human Services and Public Health Department, and the Minnesota Public Health Association, all working together towards the goal of healthy people living and thriving in healthy communities.
Welcome to A Public Health Journal. Today we're going to focus on community health centers or community clinics in Minnesota. We'll find out when and why they got started and discuss the impact that they are having on communities across our state. We'll also be looking at some of the challenges that they face during this time when our population is becoming more diverse, when the cost of healthcare is increasing rapidly, and when healthcare is becoming increasingly consolidated in large systems. Joining me in this conversation is Clarence Jones, Outreach Director for Southside Community Health Services. In addition to his work at Southside, Clarence serves as an adjunct professor at the University of St. Catherine, training community health workers. Clarence, welcome to the program.
Thank you, sir. Glad to see you again.
It's always nice to have you on the program to talk about some of the exciting work that you're doing. So let's start sort of at the beginning and with some definitions. What is a community health center or a community clinic, and when did they get started and why did they come into existence?
Well, I think that community clinics or federally qualified health centers are just the medical safety nets that the government established in order to make sure that people who are uninsured, underinsured would have access to medical services. And so it is something that has been around since 1960, 1970s. It started with the war on poverty, and it is something that is established actually all over our state of Minnesota, because we do have areas where there is a great need for medical services. And you know, many times people think about health disparity, they think only the cities, but also in rural areas, there's a great need for medical services, which community clinics, FQHCs, serve. Mm-hmm.
I know that in the 60s when they got started, we had basically two community health centers, one in Minneapolis and one in St. Paul. And we also had a bunch of free clinics that started sort of community-based that were not part of this federal effort, but they evolved into community clinics. I think Southside was one of those.
Actually, Southside was. There were three VISTA volunteers that actually came and helped us establish Southside in 1971. And since that time, it's grown in terms of providing services to the community, medical, dental, behavioral health, those kinds of things. So yes, it started in 1971, but it has grown. And in fact, you were talking before, there was a time where we had organizations called like model cities. Mm-hmm. And that's how many of these—
Pilot City.
Pilot City, that's how many of these organizations started.
Yeah. So are they still needed today? You know, we had certain issues in the 60s, and we've had a lot of healthcare reform since that time. Are they still needed today?
I think very much so. I think when you take a look at the various surveys and statistics, you'll understand that there are still many people who don't have access to health care. I think Minnesota has done a great job. I love Minnesota, so let me put that out there first. You know, I love Minnesota, but even in Minnesota, there is still some huge health disparities, especially among groups of communities of color. And I think that we have to be able to address that. And I think that the community health services or the FQHCs are in a good place to be able to help us to make sure that our state stays healthier.
Mm-hmm. So how do they differ from regular clinics?
Well, I think that one of the primary differences is that because it is a service where, or a clinic is set up so that it can serve anyone. I mean, so anyone, regardless of their ability to pay, can come to the clinic. I think the other part too is that it has sliding scale fees. I mean, that makes it a little bit different than other clinics. I mean, there are opportunities for people to be able to get services, whether they have money or not. I mean, based on their needs. But they also are many times they're in medically underserved communities, and so. this is America, and sometimes, if there's no money in that population, people may not go there. And so the FQHCs are in places where there's a great need for people to be served with medical services.
All right. Well, I've got 3 slides here that sort
Sure.
of show some demographics of the community clinic population that I think might explain it. So
Sure.
first of all, this slide here shows where the clinics are. So
Sure.
tell us about, on the left side is the statewide and on the right side is the metro area. So these are really clinics throughout the state, right?
They are, and I think that's one of the things that we want people to know is that people many times think that, again, that a lot of the health disparities are just in the cities, but when you really take a look at it, you look in greater Minnesota, there are many areas where they don't have access to medical services. And so these clinics are very, very important to have. And so as you can see, they are situated around the state of Minnesota. Many are located in the metro area, but it is important for us to continuously stress and impress upon people that there is a great need in greater Minnesota as well as in the metro area.
Yeah. One of the things that struck me is Wisconsin has a whole bunch of clinics too.
They do.
Probably
They
even
do.
more than we have.
They do. They do.
All right, so let's look at the next slide, which really shows some of the demographics. Like, who are the populations? So on the left, it sort of shows the racial breakdown, and on the right, sort of the economic breakdown. Explain what's going on here.
Well, I think that many people who don't have access to services, or many people in the metro area that may not have medical insurance, utilize the federally qualified health clinics. And as you can tell, everybody is using it. Whether they're white, they're Latino, it doesn't matter. I think one of the myths about community health services, why a lot of people may not utilize them even though they may need them, is the fact that they don't think they'll get quality services. But the reality is that there is a quality control service that is there, and it is in many cases as good as other private services. And so we have to make sure that people are understanding that everyone can access the services, but also that they will get good services as they utilize these clinics.
Yeah. And the right side of that graph shows that really if you're low income, you're more likely that's the orange bar for
Correct.
low income. That's really, people with low incomes generally tend to really depend on community clinics for their care.
Right. But actually, there are other people that have access or have money that also will utilize a community clinic. I mean, the reason I went to the community clinic was my wife nagged me for about 5 years to go to a doctor. And it was available, it was right in my neighborhood, and when I got there, it was like, man, this was just as good as going to a private doctor. Yeah. So I'm gonna stay here. Yeah.
And then the third slide really shows the fact that how it gets paid for. And
right.
You said that we have a lot of people who are uninsured, and it looks like you have about 30% in that the blue part of this graph showed people who are uninsured don't have any kind
Correct.
of insurance. The MCHP, the Minnesota Health Plans, right. That Medicaid
Sure.
kind of thing. So some of them have a source of payment, and 30% don't. How does that care get covered? Who pays for that?
Well, I think
care?
the federal government does. There are grants. They have a 330 grant that they provide for these clinics, so that there is so that clinics don't necessarily lose, or in terms of serving people. And so the federal government also provides the grant, as well as there are also sometimes foundations and other organizations that also provide to make sure that there is, again, a safety net for the community. And so those are some of the various funding sources that are available to the community clinic.
And Clarence, and I know that community clinics do a lot more than just clinical care. They do some of the public health and outreach kind of activities. And we have a little video here that I think really explains some of the things that you're doing, the clippers and curls thing. So let's roll this video and see what really happens with community clinic outreach.
Thank you.
My name is Tito Wilson, and I'm the owner of Wilson's Image Barbers and Stylists. We're located at the corner of Broadway and Penn in North Minneapolis. I've been a barber for, 21 years now. It's really an unexplainable bond that customers have with their barbers. I've gotten like lifelong friends from just coming in, visiting me, getting a haircut. They like my service, we talk, we laugh or whatever, and it becomes a bond.
It goes back to history. Barbers have always been trusted messengers in the African American community. They're just almost like ministers, as you come into the barbershop and you kind of reveal a whole bunch of stuff that you don't reveal elsewhere. You probably would tell a barber more stuff than you would tell a doctor because you have that kind of relationship.
The Clippers and Curls project, the overarching view is that we're going to try to reduce hypertension within our community. But this particular project is really designed to get into the barbershops, who are trusted messengers to talk with their clients, who are generally African American men and women, and to give them information that will hopefully begin to decrease the morbidity rate in terms of our community.
I mean, I think it's really innovative for health professionals to want to use barbershops and beauty salons to be able to get people to, understand their health. The reason why it's such an easy decision for me to have the machine in the shop, for a few different reasons. A lot of times people have issues for whatever reason, we're going to doctors or whatever. So a lot of times they may not get their blood pressure readings as frequently as needed. Having it here in the shop, I can easily convince a person, hey, while you're waiting to get your hair cut, or if it's a lady getting her hairstyle, hey, why don't you go over and get a blood pressure read.
Part of the reason why we train the barbers is so that they have some knowledge of stroke, heart attack, things like that, how it's related to the blood pressure. And then we go through a training explaining pretty much what high blood pressure is, what it can do, why it's important to check your blood pressure.
We're not doctors, but we learn how to direct people, once they get that reading, what to do about it.
We were at a barbershop in South Minneapolis called Fades of Gray. And we had a young man come in and get his blood pressure checked, and it was really ridiculous numbers, like 200 and something over $130 or something to that effect. We immediately had him go to the hospital, and he came back and thanked us for the services that we had provided him, because he was headed down a dead-end street pretty much if he hadn't got that in check.
I think what makes Clippers and Curls successful really is the fact that we brought our partners to the table and we asked them what was important for them, what was their bottom line. We asked them what would be a win-win for them. And what we found out was that we all had the same kind of goals, which was to make our community healthier. Is not only do we have stories, but we also have statistics, we have demographics, we collect information. We can do it by working together, and that's really what we're trying to show and prove every day, that we can actually make a difference.
Welcome back. We're talking with Clarence Jones from the Southside Community Health Center about community clinics in general. And Clarence, you just saw this Clippers and Curls video, and it really shows a little different aspect of how to deal with healthcare. How does this fit with community clinics?
Well, one of the things about the community clinic is the fact that because we're in the community, there are a variety of needs that will be identified. And so we as a community clinic have the opportunity as well as the responsibility to respond to those needs. For example, with Southside, people think that we are just primarily a biomedical clinic, which means that people walk through our door, we give them a shot, we give them some medicine, and we send them out the door. But we also have, with our outreach department, we have what is called a public health perspective, which means that when we look at our community, what we try to do is we try to be able to respond more quickly to the needs of the community. And one of the things that happened is that we uncovered the fact that there were many chronic diseases in our community, and we wanted to find out how do we address some of them. Well, one of the quickest ones that we found out that we could address was the one around the cardiovascular kinds of diseases. And so we started working on a project in where we were trying to find out who were the most trusted messengers in the community to deliver messages around cardiovascular health. And what we found out was that barbers are trusted messengers. And so that's how we began to work with the Clippers and Curls project.
Yeah. So to do a project like this, you need more than just doctors and nurses, because
Right.
I mean, most doctors don't know how to do this sort of community education. That's not part of their training.
Right.
So what kind of staffing do community clinics have that allow them to do some of this kind of work?
Well, we're fortunate at our clinic is that we have some pretty innovative people. They've allowed us to work with other clinics. So one of the things that we have been very comfortable with was crossing silos to say that we can't do the work all by ourselves. So we have to go into the community. We have to find those other agencies, organizations, individuals that can help us to do this work. And so we spend a lot of our time identifying those organizations and getting them to work with us. We talk a lot about staying in our lane. We know what we can do well, but there are other people in our community that have a passion, they have skill sets. We come alongside of them and we talk about what do we want to accomplish in terms of a goal, and then we just work together. And so many times when we talk about Southside in our events, we generally have anywhere from 15 to 20 other organizations.
So what are some of those partners that you partner with on these health issues?
Well, we work with Health Fair 11. I mean, we work with North Point. We work with Open Cities. We work with Neighborhood Health Source. We work with Mayo Clinic. We work with the University of Minnesota. I mean, we've got organizations. We work with the HMOs, Blue Cross Blue Shield. We work with Medica. I mean, we have established ourselves really as a convening organization, especially focusing in around the issue of how do we help our communities become healthier, and it is through public health. I always tell people, I've drank the public health Kool-Aid. I mean, I'm convinced that public health is really the way that we're going to be able to address these issues. And so what we have been allowed to do within our organization is to develop these relationships with other organizations that can help us to serve the community. So anytime we talk about our work, we always talk about the term us. Mm-hmm. And so you'll see that in terms of how we advocate for our partners as well.
So how do you, knowing that clinical care is really only a small part of what determines health, some of the other social economic issues, how do you get engaged with economic development or housing or transportation or incarceration or all the other social determinants of health? How do community clinics engage with those kinds of issues?
Well, I think part of what we have made it a point of is to being aware of what the real issues are, to be a part of the various committees and focus groups and surveys, those kinds of things. We are actually in the community all the time. We're actually in the community always trying to identify who are the people that we should be talking to. Because we are outreach, we run across all these various needs in our community, and so we have to be made aware, which is why we talk a lot about the whole idea about having community health workers. Community health workers are those individuals who are part of the community, who are aware of some of the issues of the community, but also who are aware of some of the resources in the community. And so we have to be flexible. I talk to my people all the time. Whenever we go into a situation, we have to always be willing to punt. Mm-hmm. Because in community you have so many different things coming at you, but you want to be as equipped and prepared as you possibly can be. Right.
Well, I want to talk about some of that outreach. You mentioned outreach. I want to talk about that and community health workers. But first, we need to take a little break.
Okay.
We'll be back right after this message.
Well, Thomas, you've got prediabetes. But with more exercise and a change in diet, it can be reversed.
I've tried exercising. It just makes me hungry for bacon.
I love bacon, too. And who really likes to exercise?
Not me.
Me neither.
Nobody. So we're good?
What? Oh, you still have prediabetes. Big time.
Welcome back. We're talking about community health clinics in Minnesota with Clarence Jones from the Southside Community Health Services. Clarence, you talked about outreach. Why is community outreach, so important in the work that you're doing?
I think because outreach actually gets us the opportunity to meet people where they're at. What we have tried to do in the work that we've done is to really listen to what people are saying and then to figure out what will be the most effective way of providing them with the kinds of services that they need. Many times in outreach, when we go out and we do community work, we find people that haven't been to a doctor in 5 or 10 years, especially men. Men are like that, And so we had to find some unique ways of reaching out to our community. One of the things that we did, again, in terms of our partnership, is that we made sure that we had partners from around the metro area and various disciplines so that wherever we went and the needs of the community were identified, we would be able to bring in appropriate partners. The other thing that we did that was kind of unique is that we were given a 37-foot medical mobile unit.
All right, we got a little slide for this.
We actually have a medical mobile unit that goes out into the community and provides services. And so you'll see us at various events. I think 2015, we did over 250 events in the community. I mean, so I think outreach is a commitment from a clinic to make sure that the needs of the people are met, whether they come in the door or they're in that general area. We want to make sure that people understand that there are services and access for them. And especially in Minnesota. I know in Minnesota, it's like, I'm surprised that there is such a huge health disparities because there are so many great services that are available. But we have to do a better job. Those of us who are in these community clinics, we have to do a better job of reaching out to the community to let them know just what's available for them.
Right. So what kind of providers serve your clinic? What are the kind of people who choose to work in community clinics?
Well, we have pediatricians, we have people, medical assistants, we have dentists, we have behavioral health workers. I mean, we have optometry. We have all kinds. Almost anything you find any place else, we have them in our clinic. We also have individuals who are like we talked about before. We have community health workers. We have people who just make sure that the operation is working well, that the heat is on, those kinds of things. So,
why did they choose? Why did they choose? They could go out other places, probably make more money. Why did they choose to work in community clinics?
I think for many people, there is a great satisfaction going home knowing that you really helped somebody. I mean, that's one of the reasons for me that I enjoy my work. I always tell people, I know this may not be the most appropriate time to say this, but I tell people when I go to bed at night, I lay down with two people, me and God. He ain't happy, I ain't happy. Okay? But when I go to bed at night, what I really am happy about is the fact that throughout that day, I had the opportunity to really provide some real appropriate and accurate information to people for them to be able to take care of themselves and their children. Because I believe that we have to do this not only for ourselves, but also for our children.
All right. And one of the people or groups that you talked about is community health workers. Explain a little bit, because this is a relatively new profession.
Right.
Tell us about health workers and the things that they can do and the kind of training they have.
Right. I'm really glad that about Minnesota. I think Minnesota has really taken a very progressive, positive step in terms of engaging community health workers, which are generally people from the community that they are serving. People who attend school, some for 3 months. I mean, at St. Catherine's, they go for 9 months. You know, and then there's the opportunity there to go not only to be a community health worker, but also go in to become a medical assistant or become a nurse, those kinds of things. But what community health workers are able to do is they're able to engage people at a level where other people may not be able to do that. They're trusted, again, like the barbers, they're trusted messengers in those communities. And given the appropriate training, which I believe is important, given the appropriate opportunities to learn and to grow, that's going to be how we're going to be able to address health disparities in this state.
So do they reflect the community that they serve? Is that one of the benefits that they have?
Very much so, very much so. But people sometimes ask me, like, they say, well, you know, I'm not from that community. Can I be a community health worker? And my answer to them is yes. I think what we're looking for when we talk about serving people, we're looking for authenticity. We're looking for honesty. We're looking for integrity, you know. And people believe that just because you don't have that experience or you weren't born like that they can't serve. And I disagree with that. But I think that you have to go in there with a mind, and you have to go in there with the thought that, you know, you're there to serve.
All right. And so what are some of the challenges that you see community clinics facing here in the next several years? Because as I said in my introduction, you know, we're becoming more diverse. That fits into the wheelhouse of community clinics. But we're also, the costs are going up. It's being more expensive.
Sure.
The government is spending less on wanting to spend less, and healthcare is becoming much more consolidated, which seems to be a pressure that I think would really be threatening to community clinics.
It is, and I think that part of Dr. Ellinger, why I am so intent on this is that we have to do the job, you know, really whether the money is there or not. You know, we have some very sick communities. One of the things that really drove me to this work was the fact that, I realized that in some communities they were spending $40–50 million a year just in certain zip codes, and people were sicker now than they've ever been. That just didn't make any sense to me. And realizing that there was going to be a lack or a drying up of the money, we have to figure out some ways of making this work more effective. The challenges that we're going to have is the fact that money is drying up. We have to have a pipeline of people who are engaged in this work. And so we have to do a much better job, I think, in terms of letting people know how important this work is.
All right. Clarence, thank you very much for being on the show.
Thank you.
The important work that you're doing and community clinics across the state and the country. Thank you. I'll be back with a closing comment right after this message.
Hart, what's going on? I'm leaving. Why? What did I do? Not enough. You constantly ignore me. You barely eat anything healthy. You're half as active as you used to be. The pressure is just too much. I quit. Okay, I get it. I'll do better. Just, please, don't leave. Okay, but remember, if I go, you go.
Listen to your heart. Don't let it quit on you. Uncontrolled high blood pressure could lead to stroke, heart attack, or death. Get yours to a healthy range before it's too late.
When community health centers or clinics got started in the 1960s as part of the war on poverty, they were not organizationally located in the Department of Health, Education, and Welfare. Rather, they came out of the Office of Economic Opportunity. This underscored the fact that health and economic opportunity are closely linked. In fact, one's income is one of the greatest determinants of health and longevity. What most people don't recognize is that the war on poverty was really a health program, and that the creation of community health centers was really an anti-poverty effort. What was true in the 1960s is still true today. Health and economics are closely linked. If we are to really improve the health of everyone in our society, we should learn from some of the successes of the war on poverty, which not only helped reduce poverty, but also reduce health disparities. It did this by incorporating a broad definition of health, adopting a health in all policies approach, and building the power in communities so they could create their own healthy future. Many of the problems we are facing today are similar to those our country faced in the 1960s. And some of the successful interventions used in the 60s could hold the answer to some of our challenges today. We need to learn from our history. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.